And my topic will be palate-free approach today. I also want to thank Geistlich for the invite to present on this webinar. My talk will be in 3 parts. I'll discuss our 10 keys concept, which in part, Thomas's information that he gave in the previous webinar seminar. It's part of our 10 keys. I'll go into clinical cases using our Fiberguide as well as Mucograph in private practice. Our ultimate therapeutic goal, long-term functional and aesthetic results, predictability that does no harm to our patients. As periodontists, we preserve the natural dentition when we can, along with a happy patient who will send their friends and family, and who also writes a 5-star Google review. Half of my clinical patients come from the internet, new patients, and they come through Google reviews. Google drives our patients to our practice, literally like a fine restaurant. The recent Swiss cheese model, when we look at a surgically driven approach with the surgeon making poor decisions about placement, we see complications. And these are all patients that I've treated in my practice. And we'll go into some of the reasons for that. One of the reasons not is that the checklist, any checklist has not been used in these cases. But when we use prosthetically driven approaches, as we did in all these central incisors, where the central incisor implants are stored, the contralateral tooth is a natural central incisor. We presently have 4 studies that'll be published. The first study will be coming out hopefully within this year with my coworkers from Temple, Ping Wang, and my really good friend Maurizio Roggio and Deborah Diaz from University of Moringa. The 5th consensus conference, we had 3 papers in our group. Danny was in our group, and Stephen Shen and others, and we saw that the 3 papers led to the consensus statement and recommendations regarding optimizing aesthetic outcomes, and a team protocol, which if strictly followed, would have a high predictability of preventing aesthetic complications. As we as periodontists, we have become repair odontists. We see complications still with all the information that's in the literature, for many, many years, we're still seeing this. And the central incisor is the area that we see the most complications in. And when we do a surgical approach with just the surgeon making these poor decisions, and we know from Danny's material, over 90% of surgical complications, of aesthetic zone complications are due to poor decision-making by the surgeon. So we came up with 2 papers. These are follow-ups to our consensus conference statements. Besides Thomas, he's very much in our papers in the bibliography, and Joe Kahn as well. And these have been my clinical people that go to. So we have the checklist, and we'll talk about that shortly. So when we look at a 10-year prospective study on single immediate implants with immediate provisionalization, all the cases were thick phenotypes. So the clinicians felt they did not need to add any connective tissue grafting. 33% still demonstrated greater than or equal to 1 millimeter midfacial recession. When they looked at their risk factors, the buccal shoulder position of the implant, it was towards the buccal, and that's part of our key number 4, where we need to be down the palatal wall using a surgical guide. No connective tissue graft, which is a very important key, as we know from the past lecture. We need a thickness in vertical and horizontal. Convex emergence profiles, which are really our restorative keys, 8 and number 9, and a central incisor position, as myself and Maurizio have experienced in private practice. This is one of the patients in our study that we'll be publishing. 28 patients from my practice, all CBCT analysis was done in University of Moringa. And this is a patient that presented to me in 2013. Fairly thick tissues. We had good convexity. 7 years later, we see the recession facially, but really what we see occlusally is this concavity, which we do not see when we use a connective tissue graft. So let's talk about Fiberguide for phenotype conversion. The product characteristics, once it's wet, it swells about 25%. So that needs to be passed to the patient that this is something that's going to happen. Generous flap release is noted. Loss of approximately 50% of that initial device is going to happen within the first 1 to 3 months. And our friends in Zurich have shown low healing complications. And when the Burden Group did their SEM on their study published in IJPRD, this is what it looks like in cross-section. And we see a lot of darkness, which is basically just air, and we see some of the material. And this is a case where I was the repairodontist on this case. I removed 12 and 13 previously placed. At the time of healing, there was a real concavity of soft tissue, added the Fiberguide, and we could see the thickness of this tissue in vertical as well as horizontal. And I took the tissue sample, and this is what we see in the histology at 20 magnification. So there's 3 important clinical recommendations: tension-free closure, preferably with a non-resorbable or slowly resorbable material. I really like this glycolon material since COVID because it stays in a little longer for about 4 weeks or so, and I don't have to really remove it. Reduce the thickness of the product. We're reducing it a couple millimeters, usually to about 4 millimeters. We're beveling the shoulder and maybe laterally as well if we're placing it for a single tooth. We use a new 15 blade, and then we squeeze the product together with dry fingers. And we can see here going from here to here. And so I'm treating this like a connective tissue graft. Our first case with the Fiberguide is a 13-year-old post-orthodontics. We see beautiful ortho. I go to her upper right palate, is very thin. This is back in 2018. So I decided instead of going to the other side of the palate, we used the Fiberguide first, covered it with some palatal tissue, a connective tissue graft. And what we see at 1 week is at 25% initial swelling, which will go down by 1 to about 3 months. So this is about 6 weeks, and we see definitely a significant difference. And we see what I like to call phenotype conversion, and as the biotype conversion is Joe Kahn. And we start out with a ridge lap in number 7. We see the ovate ponic, which has been developed by the restorative dentist, and we have a bonded ridge that'll get her through till her mid or late 20s. Case number 2 is a treatment of implant complications of number 7 and 10, but we'll deal with number 7 as we treated this with just soft tissue substitute. Again, this is a repairodontist case. The implants were placed in a screw retained position, which was good. Otherwise, we would consider removing them. This is a gal who was 18 on her way to college. She took a selfie. You know, you're in trouble when you see selfies from the patient. She did not like the darkness that we see in the mid-buccal all the way coronally. The CBCT showed that the threads were exposed, but there was no probing. The gummy smile was not taken care of or even thought about. The implant was placed too shallow. So we did some crown lengthening surgery using only a buccal approach with a deep periosteal incision. We have incision back to the distal of number 6, mesial number 5, using the Fiberguide material and placing that and suturing with polypropylene. As it was just a palatal approach, this tissue will heal. And we could see at 4 weeks the thickness of the tissue. And when I see these peri-implantitis cases, which I feel we could possibly save, I get my team involved. And the team is a prosthodontist, Harry Rendell, for a surgical prosthetic approach, as Kelly has mentioned. You can see there is no emergence profile at all. As you could see how much the second provisional needed to be made to push the tissues out. So at 2.5 years later, we see no probing depth around number 7. We've got this now convexity where concavity was. So there's a very simple solution to be able to deal with this type of situation. If it was my daughter, I definitely would not want to take this implant out. Case number 3 is non-restorable tooth number 12, low lip line. We got good apical bone. My concern is that there's teeth on either side that have been restored, so I do not want to be the one to have to re-restore these if we get recession. The aesthetic risk assessment is used for every single patient in the aesthetic zone, and she has realistic expectations. So this is key number 1. Key number 2 is a cross-sectional x-ray where I can see the thickness of the buccal plate, which is thin, less than 1 millimeter, which we see in about 90% of the cases. I like to place the implant about 1 millimeter apical to the healthy, intact buccal plate. And these are our keys. There's 2 diagnostic keys, 5 surgical keys, which include phenotype conversion, and also 3 prosthetic keys. So we'll talk about this. And this is our surgical and prosthetic checklist. I use the intact buccal plate to make my decision as to what width implant. I want a buccal gap of 3 millimeters, and that has been documented. So I'm going to be using the BioOS collagen material because it's slowly resorbing based on Maurizio Roggio, Jan Linda's studies. A surgical guide is always fabricated. I'm using piezo surgery to get positioned exactly where I want it. And we measure that buccal gap, and we have 3 millimeters here. That buccal gap is filled with the BioOS collagen material. On the outside, we're contouring just like I would do a soft tissue graft, squeezing with my fingers, placing it under the flap. There was no palatal flap done. Again, discussing with the patient about the swelling. We're in a good prosthetic position, and as Tomas has said, we're at least 2 millimeters subosseous here. If I was to use the Straumann healing abutments, nothing like a customizable abutment, which is anatomically shaped. So pre-treatment, at 3 months, we see very good healing. We see this thickness of tissue to the facial, and the final screw retain restoration, which is key number 10. Just got this patient in about 2 weeks ago, and we see very nice papilla healing. We do not have any showing in the margins, and we have very good thickness and a very happy patient. Going into case number 4, non-restorable tooth number 9, we go through the same. This is a checklist that we use on every one of these aesthetic zone patients. Key number 1, key number 2. In this case, I'm going to use a narrow connection, 3.3 millimeter, even though we have a wide buccal plate, but we got a pretty significant undercut. We're planning for a screw retain restoration. Surgical guide, I'm using the Boozer membrane instrument going from line angle to line angle, and this is an envelope that is created. We're going to tuck the Fiberguide in after we squish it. And also we could see right in here, we already got that contained. BioOS collagen is packed almost like an amalgam, so I put some pressure into placement. And chair side, as the anatotem do not make narrow connection healing abutments, I will make this chair side. And going from pre-treatment, and this is the key when it comes to the placement of the provisional custom impression coping technique, which are 2 of the keys also, which is key number 7 and 8, and key number, number 8 and 9, and number 10 is the screw retain restoration. Seeing the thickness of that tissue again, and seeing the coming back of the papillas, and that could take up to 3 years or more in these cases. And again, looking at the depth of these implants. We use the Fiberguide chair side. Every mandibular case, I will consider using it. So because I do not want to go to the palate to make this palate-free. Non-restorable tooth for multiple reasons. We do our cross-sectional analysis, buccal plate status. In this case, because of the recession, we could see we have a dehiscence. Since we're not in the aesthetic zone, we're going to deal with this as a combination of GBR, using BioOS collagen with a collagen membrane, which is BioGuide, and then topping that off with the tissue thickening device, which is the Fiberguide. As Danny has shown with histology, using the patient's own blood, and we get that from the local local flap area, and we see very good healing as there's many growth factors in the patient's blood. So we're packing the site. Remember, there's a dehiscence here, covering that with BioGuide, and we're going to tuck in a piece of the Fiberguide over that for tissue thickening. And when we see the phenotype conversion, when we started, and we can see the tissue actually in a more coronal position, as Tomas has said, this vertical position is very important, along with that horizontal position. Moving into a more complex case, and this is a full arch immediate load case. This was done about maybe a year and a half ago, where we're placing 6 actually placed implants in immediate position using the patient's own bone. So this is at 200 RPMs with no water. That's been documented. The Fiberguide BioOS collagen mixed with calcium sulfate. And as this is going to be large buccal gaps that are going to be bone grafted that you could see in this position here. So 21, 22, and 27, 28. And we actually use the Fiberguide all the way around to this edentulous site on the right side, and using the BioOS collagen also in this area as well, because we want to do ridge preservation. So the BioGuide is going to be covered with the Fiberguide. And we've published on full arch restorations, and we've been using this team approach since 1994 for indirect method for full arch provisionalization. Surgical guides are used on all cases. You can see the thickness now of the tissue. This is a fluorochromic gut that was used in this case. So using the indirect technique means the impressions are taken that day. The provisional is going to be placed by the restorative dentist, who's ITI fellow Harry Rendell. Practices about a block from my office. Metal reinforced provisional. Because of COVID, this case is really extended pretty far. The second provisional was placed as our final restoration is going to be full zirconia. Orthodontics was completed in the upper. We're just about in position. And the restorative dentist took these pictures showing the phenotype conversion. And again, we used the Fiberguide all the way around to the edentulous site number 29. We did contour grafting a la Danny Boozer and Byrne with BioOs and Fiberguide to thicken the bone in this area. So post-treatment, these again were taken by Dr. Rendell, and this case will be published with Jeff Ganalis, one of his cases, in an upcoming compendium in the fall of 2021. When we look at a study that was published out of Zurich's group, using either the Fiberguide, the VSCM versus connective tissue graft, their practical implications were implant sites previously augmented with either the Fiberguide or autogenous connective tissue grafts rendered stable outcomes up to 3 years. And we could see Rochelle's case, which is 2 years, everything is very stable. And Patty, this is part of our single tooth implant study showing the connective tissue graft. So she's in that, the first study with connective tissue graft that we'll have published. So let's look into Mucograph. Published with P.D. Miller, who's actually another very close friend. He's like my older brother, to say. He's been on all these Civil War tours, Danny, with us over the past dozen years. And everybody knows who P.D. Miller is. So the Mucograph have two structures. One is compact macro structure, which we see here very easily sutured to, provide stability. This is going to be in an open environment. We see a spongy microstructure, which supports the blood clot and ingrowth of the tissue cells. And I describe this to patients as a biologic bandage, and this is the undersurface. The benefits to all of us is easy handling and suturing, but this is critical in a dry environment, and we'll point to that shortly. Significantly less surgical time with less morbidity. I could use one piece and do this in one visit, and going from 19 to number 30 as we did here. And I like to extend that one tooth on either side, and we're planning on placing implants in 19 and 30. So case number one, we documented progressing of attachment loss in periodontal maintenance between our office and Dr. Gary Knack, ITI fellow, restorative dentist. These are all Miller class 3s and 4s. No root coverage is necessary. The patient has no aesthetic concerns. There's no sensitivity, but she was concerned about the progressive attachment loss that we discussed. So we talked about, and this is 2012, we discussed the benefits of the different procedures and the negatives, and she chose the Mucograph, as we didn't have to go to her palate. So again, one piece could do this in one sitting. Very important to get either a CBCT or a Panorex to isolate the inferior alveolar nerve and also the mental foramen. You could see we placed 4 implants in the maxilla about 10 years prior. So she's been in maintenance for quite a long time for a locator case. And this is the way things should look after it's been placed. These are all 6-0 resorbable regular gut. I've beveled coronally at the margin, just coronal to the MGJ, and periosteal scarring apically. There was a study in the medical literature which showed significantly faster wound healing with Mucograph compared to using Mucograph on burn patients. So this is in the medical literature, and this is what we see routinely. And I generally do not use a periodontal dressing. We let this just heal. And apically, you could see a secondary intention. And now this is at 2 months, you see the scarring, but we see really nice healing. And we know from the literature about 2 millimeters of keratinized tissue and about 1 millimeter of attached gingiva are desirable to maintain periodontal health around teeth. So again, phenotype conversion. And what I noticed with my cases, I was asked to do the corporate forum in Chicago for the AAP 2019. I started looking at these cases closely and saw the phenomenon that we see with connective tissue grafting of creeping attachment, pre-treatment and post-treatment. And we'll see this more in upcoming cases, but very stable procedure. Patient was extremely pleased with the results. Another case, in her late 60s, progressing attachment loss documented again in maintenance. She's been alternating with the restorative dentist. We could see recession in here. She was concerned about that as well as the lower anteriors. So we're planning on 22 through number 29. We were able to use periapical x-rays to isolate the mental foramen. And again, the periosteal scarring apically is very important. We could see we could have had better hemostasis in the placement. I'll show you how we do that. But again, significantly faster wound healing with Mucograph. But look closely here, pre-treatment and post-treatment. And the same thing in lower anteriors. We've got a number of areas of creeping attachment, which I'm not even sure has been documented, but we've documented with a number of these cases. Case number 3 is a patient who's 73. Her last procedure to restore is the lower anterior. She had the upper reconstruction done by Harry Rendell when he was in pros school. So this goes back to the mid-1980s. So this is the last area. Patient was given the opportunity of different types of procedures, from free gingival grafts to alloderm, which I'm not a fan of in this area, or the Mucograph, and she chose the Mucograph. She had no root sensitivity. Again, she's in her late 70s, mid-70s at this time. And in 2020, when she represented, because the upper reconstruction had failed, so we recently completed an upper immediate load reconstruction on 4 implants, and that is in the process of going to completion. So we see the phenotype conversion and significant creeping attachment in this area. Patient that I treated a year ago, she came in because of this area. And a lot of times patients will come in and say, listen, I'm having trouble with plaque control. This is a pontic on a bridge, and I just have a lot of sensitivity on brushing. What can I do? So as a clinician who documents every single one of his cases, I showed her this picture down in here. I said, this is lacking attached gingiva. These are now everything from 1 to 3 Miller classification. And she said, Bob, I want to be proactive. I'm like that with my health. I take vitamins. I'd rather do this now than come back and do this later. So one surgical visit, we're going to take care of going from number 19 to 27. Again, I like to extend one tooth on either side. But what I want you to look at here is a couple things. Is that we beveled coronally. You can see how it beveled higher in this area here. Periosteal scarring is really important. Thus, the position of that mental foramen, you need to be above that. And what you can see also is the osseous is exposed here, which we know is not an issue. And this is very difficult tissue to work with in the posterior mandible without sometimes doing this. One piece took care of that in this area. And then in the lower anteriors, we took a second piece of it. Actually, it's one piece cut in half. You see, I've connected the two. This is a 6-0 plain gut. What I did here, and this is important, prior to placing this material, we're using 1 to 50,000 locally with epinephrine. We're also using 1 to 50,000 in a gauze with my assistant pressing in this area, just light pressure. I got up to check a hygiene patient, so I was probably going about 5 minutes, so that when I place the material, this is what you want it to look like. If it looks like this when you place it, this will be very difficult to use. So this is what you want. You want good hemostasis so that at the end, with taking pictures and everything else, it's going to look more like this. And when we see the patient at 2 weeks, again, at 2 weeks, we see a little of secondary intention healing. At 4 weeks, it's all gone. So if you look at 3 weeks, our normal post-ops are 2 weeks and 4 weeks, you would see this totally healed. And then we go to 4 weeks, and then we go to 1 year, which was a couple weeks ago. We see the periosteal scarring. We see a nice zone of keratinized tissue. Again, patient wasn't concerned about root coverage. A lot of times it's more in our heads than in the patient's heads. Patient's on no medications, so there's no concerns about medication-induced xerostomia. And she knows that in a year when I see her next, we're going to be seeing a yearly basis to check for the coronal growth, which is the continued creeping attachment, which I hopefully we'll see in that area. So case number 5 is an 8-year-old. The patient was referred from my wife's practice, Cheryl, who is a pediatric dentist with both of my kids. They practice together, so that's been our COVID bubble with our grandkids, so it's been great. This is a case that I normally do not treat 8-year-olds, but there was a history documented in their chart that this patient is an excellent patient. I met him, met the mother, everything was terrific. Mother was concerned about this. I said, these are our options. We can go to the palate, or we could use this Mucograph. It's noted in the treatment plan, and the mother chose the Mucograph. So I'm going to do everything that we talked about, the periapical scarring, the beveling of the tissue at the coronal margin. See, I've left a little bit of the coronal margin here. There really is no recession here. And using all the suture I would do as with the free gingival graft. So we've done some periosteal suturing as well. At 3 weeks, the patient had told me, the mother had said, he had no discomfort at all. He was playing with his brother earlier, just really within a couple hours of the procedure, and he had no pain whatsoever. I saw him in October. We have a nice zone of keratinized tissue. We could see the scarring here. And we know from the research, attached gingiva will increase in width between 23 and 45, and there's no question it will increase in the mixed dentition to the fully adult dentition. And as patients are driven to our practice through Google, just like we go to find restaurants because we Google them, Dr. Levine performed soft tissue grafting using Mucograph for my 8-year-old son in order to increase thickness on his bottom row. The procedure went smoothly and recovery was quick and virtually painless. The results are remarkable, and I now have peace of mind knowing that my son's adult teeth are protected. I'm especially impressed with Dr. Levine's use of Mucograph, and I'm glad that this was an option for my son. The patient's mom, Marla, did Google what Mucograph was, so she had a good understanding. She was happy we used it, and this is now on our website also. So the benefits of the Mucograph: easy handling in a dry environment, very, very critical, using 1 to 50,000 locally and on a gauze with pressure. Significantly less surgical time. We are able to do probably twice as much in about the same time. It's palate-free. There's no morbidity from the palate. Better color match than a free gingival graft. We're seeing this phenomenon that we see with free gingival grafts, which is the creeping attachment, which is now documented. And during this time of COVID, I'm giving patients this option, and they're taking this option. It's significantly less number of visits, less number of post-ops, and we're one and done with a lot of these cases. Improved PROM, so patient-reported outcome measures and Google reviews are important for our practice. So in conclusion, the palate-free approach using Fiberguide is designed for gaining soft tissue thickness vertically and horizontally in a submerged environment for phenotype conversion. The Mucograph is gaining width and thickness of keratinized gingiva, which is good color and texture match for an open environment healing for phenotype conversion. And never forget our therapeutic goals. We want a happy patient who will send their friends and family, write a 5-star Google review. PROMs of the patient-reported outcome measures is part of their experience. And he who fails to plan is planning to fail. And actually, Danny, a couple hours ago, I put this picture in at our monument, the 69th Pennsylvania Monument at Gettysburg, with Ernie and my wife, Cheryl. And I highly recommend this quote, and I highly recommend the Splendid in the Vial. And on that note, again, Danny, thank you for the intro, and thank you, Geistlich, for the invitation.
Thank you very much, Bob. Now let's hope that I will get back. Yes, look here, I was able to fix my laptop. That's hard to believe. I was watching very carefully. Of course, this is a Perio field in the second part, but I see that you are using both substitutes for soft tissue augmentation. And I think it's very important discussion here. Now tell me, Fiberguide, as you have mentioned this name, study with Vivian Chapuis, you see. Do you always submerge that? I think you said that, and I want to make it clear that people understand, or you leave it open as well?
No, I like Thomas, I submerge it under the flap, but I could do this mostly on a single stage surgery, as we've been doing with ITI/Straumann implants since early 1990s.
Okay.
Yeah.
And I think you made a very important point, because Fiberguide is rather thick. So you're going to cut it in a thinner portion, so it's not so voluminous. Is that correct?
Yeah, in your study that you show in IJPRD, you show the whole piece over your contour grafting. which
Yeah.
I generally would cut that 2 millimeters, so it's 4 millimeters, and bevel coronally and bevel the side slightly, so that it's.
For how long? For how long do you use it now? Then, so how long is your clinical experience?
Early 2018, so it's about 3 years now.
Okay, so quite 3 years now. Huh? Well, that's very good. Now, do you never use any connective tissue grafts these days? Has it completely converted? Or you?
No, when I'm on the palate, when I'm treating an upper jaw for whatever reason, I could, if I'm using like a premolar type of implant, I may just go right to the palatal tissue right there. I still use connective tissue. I use alloderm in the practice, but I use a lot of Fiberguide in the instances where I described today.
Okay, that means that the selection criteria will be an important issue when you have a given case to make the decision. When do you use the connective tissue graft from the palate, and when do you go for the new alternative?
Yeah, well, I've used the Fiberguide for root coverage, but it's in cases where I've run out of connective tissue graft. Say if I'm treating 3 teeth and a molars there, that I do not have enough connective tissue graft, instead of going to the other side of the palate, I'll use the Fiberguide. I've actually had really good experience. My practice is about 80% implants and reconstruction. I do still do a lot of connective tissue grafting and Fiberguide. So that's where I'm moving towards a little bit more experimenting, which one of our speakers, I believe our next speaker, will be dealing with that. I'll be very interested to hear that.
Yes, that will be very interesting. Now, I think it's important to make the point. You see that actually we are moving with our treatment modalities in a direction that we can use the invasiveness for the patient and the morbidity. So I really like that. And I think we made a great progress in the last 20 years in implant therapy at large. But this is another very important piece when we talk about soft tissue augmentation. I think we need more long-term experience to come up with clear guidelines when to use what. But I'm very impressed to see that we are making really progress with this replacement grafting material.
Agreed.
So Bob, now you made this lecture last, I think, Saturday, but you made it at the time I was already in the bed. Can you send me the link to have a look at it? Because I'm most interested in this lecture.
I will. I'm giving it again in the fall, so I will make sure it gets recorded. It hasn't been recorded. I keep forgetting to do it. So
okay, then do that in the future, because you need to get an international attendance, because you see you will have some in Japan, in Australia, and in South America, and that's a huge matter. What we have here, you see, this is a global audience than what you have.
Yeah, thank you.
Okay, Bob. Thank you so much.